So hello guys, welcome to the Parson series and this is part 7 of the cornea. So last time we have already done with the viral infestations. Today we are going to do with the parasitic infestations of the cornea, the protozoal infections. The protozoal infections, naam sunte hi, what do you get in your mind? Is the acanthamoeba keratitis. Yes, so acanthamoeba keratitis can be devastating infection if it is not recognized early, and for you it is important as a corneal ulcer in the contact lens users, right? So its occurrence is frequently associated with which contact lenses? Soft contact lenses. And if you remember, you have got this question ample number of times and you have directly messaged me also. So whether it is soft contact lenses or hard contact lenses, which is actually leading to this acanthamoeba. So it is more common with the soft contact lenses. The usual source of infection is the saline solution. The saline solution that you are using to clean or store the lenses. Also, it has been seen to occur in the non-contact lens wearers, may be related to swimming or the bathing in the contaminated water, because acanthamoeba is a free-living amoeba which is present in the soil. So maybe due to the contaminated water, it can reach, and that is the reason it is also associated with the trauma with the vegetative matter. Now, whenever I say trauma with the vegetative matter, it is actually the fungal corneal ulcer that comes to our mind, but this can be a confusing feature because contaminated water or the vegetative material can also be soiled. So that soil can actually cause the acanthamoeba keratitis. There may be no antecedent trauma, so you will get no history of trauma, and the infection is often unilateral with the formation of ring infiltrate. So I would definitely say that these two words are really important. It is usually unilateral, and ring infiltrate is always used in connection with the acanthamoeba. The epithelium is intact initially but has a mottled dendritiform appearance. Now, other important thing is we have a dendritiform appearance. So due to the dendritiform appearance, it can confuse. We can confuse with the viral keratitis. And because of, contaminated water and the vegetative material, you can confuse it with the fungal keratitis also. Ocular pain is severe, perhaps due to the deeper linear stromal infiltrates which are localized along the corneal nerves. So basically what you are getting here is the radial keratoneuritis. You are getting the radial keratoneuritis. We are getting inflammation along the corneal nerves. That is why it's very painful. However, the diagnosis is usually missed in the early stages as the clinical appearance mimics the viral keratitis, a non-healing corneal abrasion, and fungal keratitis. So they have simply given you the DD. This is the DD of acanthamoeba keratitis. You can confuse it with the viral keratitis, fungal keratitis, as well as the non-healing corneal abrasions, right? So you can look at this. This is your acanthamoeba keratitis. You can look at the ring infiltrate also. And as I always say, these images are really important and can be asked directly. When diagnosed, early keratitis may be treated successfully. They have given you the treatment also. Treatment is the topical propamidine isothiionate along with the polyhexamethylene biguanide. This is also susceptible to treatment with the topical chlorhexidine. We have neomycin, clotrimazole, miconazole, oral ketoconazole, itraconazole. So there are so many treatments, but yes, the first line of treatment will be your topical propamidine isothiionate along with the polyhexamethylene biguanide. Right. Coming to the helminthic infections, we have got the onchocerciasis, and that is not really common in India. Corneal involvement in the patient suffering from this can include the punctate of fluffy snowflake corneal opacity. So basically you can learn about the snowflake corneal opacities. We have a snowflake cataract also, and this I have been telling from the first day that we have got same name signs in cases of ophthalmology. We have got the snowflake cataract also, then we have got the snowflake corneal opacities also, oil droplet reflex also, oil droplet cataract also, shield ulcers also, shield cataract also. So another thing, right? Okay, so these are due to the presence of living or even dead microfilary peripheral corneal scarring due to sclerosing keratitis, irregular pigmentation. And what are the other things you can have? You can have sclerosing keratitis, irregular pigmentation. You can have even the calcification. The scarring could be due to the death of the microfilary or as a result of reaction to the presence of these living microfilary. So it could be a reaction also, or it could be the death of the microfilary. In the early stages, what is happening? The corneal lesions are reversible, but once more advanced scarring due to sclerosing keratitis develop, then the visual loss is permanent. So in the initial stages, there could be scarring, but afterwards, the visual loss becomes permanent. So obviously it will become an important cause of the diminution of vision blindness, and that is why onchocerciasis is also a part of Vision 2020 program. Now talking about the immunologically mediated diseases. So first in this comes your filignular keratitis. So specifically speaking, it is a keratoconjunctivitis, filignular keratoconjunctivitis. And what are filictins? Filictins are actually the nodules, and specifically they are found at the limbus. So most common area where you are getting these nodules of the filictins are the limbal areas. They may also occur within the corneal margin. The fact must be emphasized that disease is essentially conjunctival, and when the cornea is affected, it is the conjunctival element of the cornea. So basically it's never only keratitis, it is always keratoconjunctivitis, and even if the cornea is affected, it is actually the conjunctival part of the cornea which is affected, the epithelium and the superficial layer. It has been noted that it is an allergic reaction to the endogenous. So we have talked about this in the topic of conjunctiva. So it is, basically it's an endogenous allergy to the staph proteins or the tubercular proteins. So if I talk about the corneal filictin, it's a gray nodule slightly raised above the surface, and if the epithelium is breaking down, it is converting into the ulcer, then you will get a yellowish ulcer. Corneal filictins are localized infiltrations of exactly the same nature as we were having the conjunctival filictin, so you can consider them as same. Most of the time it's keratoconjunctivitis. They may become absorbed without the destruction of the superficial layers, and that is the reason why they are not causing any permanent opacity. You have to understand this, that out of the 6 layers of the cornea, which layers are getting destroyed? So whenever it is the Bauman's layer, you will always get the scarring and corneal opacity. The epithelium is readily destroyed, and the denuded epithelium will become infected by the staphylococci, and that can lead to superficial ulcer. Treatment is again same as that of the filictinular conjunctivitis. Talking about the acne rosacea. Acne rosacea is generally seen in the elderly women, and it is associated with the ocular irritation and the lacrimation. Whenever I am talking about the immunological mediated diseases or the allergic diseases, basic thing that we are going to get, basic complaint that we are going to get is not the discharge. Then in that case, it is the irritability, the watering, lacrimation that is there. In addition to that, slight mucopurulent conjunctivitis and infiltrates can be there. And the thing is that it is frequently recurring. It is intractable, and iritis can also be present in the severe cases. So it's a acne rosacea. You can see the small acne-like areas are there. You can simply point out here. And we have got the vascularization, due to which the name rosacea has been given to it. Local treatment is usually disappointing, but it is similar to that for the filictinular keratitis. So treatment is same as we were giving for the filictinular keratitis, that is the corticosteroids. Whenever we have immunological mediated diseases, you only think that you are going to have in the treatment is the steroids. So same thing. The essential treatment, however, is that of the skin condition. You can also give a course of systemic tetracycline. It has been seen that whenever we have the chances of perforation, installation of the tetracycline or its group drugs are often helpful. Patients will receive 250 milligram tetracycline QID you can give, or the another drug which is important in its group also, that is doxycycline also you can give. Then talking about another ulcer, that is your marginal ulcer. This marginal ulcer is also called as a catarrhal ulcer. Why it is called as marginal? Because it is near the limbus. That is why, and it is especially occurring in the old people. So this ulcer is actually again an immune reaction to the toxins which are produced by Staphylococcus organisms, which are the flora, which are already present in the conjunctival sac or the lids. Especially those patients who have been affected with the chronic meibomitis or the blepharitis. So they are already having some kind of infection with this staph, and this can occur also in association with the chronic conjunctivitis. So there are 3 conditions. We can have chronic blepharitis, chronic conjunctivitis, and chronic meibomitis, which can be caused by Moraxella or Haemophilus. You can see this is a kind of small, marginal ulcers which are occurring due to the staph hypersensitivity reaction. You can clearly see. Clinical features they are typically located at the points of contact with the eyelids. So whenever we have the contact of the eyelids with the cornea, which are these are your 4 o'clock position, 7 o'clock, 10 o'clock and 2 o'clock. So I think that makes a sense. These are the positions which are making maximum contact between the cornea and the eyelids. They are shallow, slightly infiltrated, and you will always see a clear area between the lesion and the limbus. They are often multiple, and a very, very important thing, a neuralgic pain. You are going to get a neuralgic pain in the face and the head, and these kind of neuralgic pains are the worst pain. So these kind of ulcers are giving you maximum pain. Frequently the ulcers will become vascularized and the vessels will persist also. This is your marginal ulcer. More serious and rare forms of the deep marginal ulceration may also occur with the polyarthritis nodosa, systemic lupus erythematosus, vaginous granulomatosis. So whenever we are having the associated connective tissue disorders, we can get the deeper vascularization, which is due to the deposition of antigen antibody complexes, right? If you look at the treatment, because it is mostly associated with the staph, so you can give the antibiotic, then you can give the hot fomentation, the lid massage, cleaning of the lid margins. You can apply the ointments also, and if it is required, then you can also give the local course of oral doxycycline. Along with this, because it's immune mediated, you have to give the steroid drops or the ointment. In severe cases, you can even go with the systemic steroids and the cytotoxic drugs. So, this does not mean that in every case you have to give the systemic steroids or the cytotoxic drugs, but yes, in the intractable cases, you may even have to go up to that. Coming to the chronic serpiginous ulcer. Chronic serpiginous ulcer, rodent ulcer, the Murine ulcer. So there are so many names of the same ulcer. Serpiginous is snake-like ulcer. Rodent is your rats, and Murine ulcer, because it's an immune mediated ulcer. So it's a rare degenerative superficial ulcer which is starting from the margin and it is spreading circumferentially and axially. So it is spreading in a snake-like fashion. So serpiginous means that it is actually spreading in a snake-like fashion, and it is not going through and through. It is a rodent ulcer which is making the small burrows. It is making the small burrows. There is no through and through perforation, and it is starting from the periphery and going towards the center. Okay, if you look at the etiology, exactly it's not known, but it has been seen that some components of autoimmune etiology are there. We have autoimmune lysis of the epithelium, and there is release of the proteogenolytic as well as chronogenolytic enzymes. Symptoms may, again, it's a very, very painful. Perforation is rare, severe and persistent neuralgic pain, and the lacrimation is there. It commences as one or more gray infiltrates. So basically it is a snake-like fashion which is starting in the form of gray infiltrates which break down to form small ulcers. So perforation is very, very rare, and this ulcer is undermining the epithelium. So we have the advancing borders overriding margins. That too are very, very important factors. Advancing borders, and then vascularization is very, very common. We have advancing borders, we have overhanging margins, advancing borders, overhanging margins, and perforation is rare because it's going into the small burrows form. It's not having the through and through perforations. Bilateral involvement with severe pain and relentless progression. This is the malignant form, is more common in young adults. Mild form is more common in the elderly patients. Now, this is diagnosis of exclusion. This is again important, whenever we are getting a question of Murine's ulcer. Basically you have to go with the diagnosis of exclusion, but most of the time they will say early vascularization, advancing border, overhanging margins, rare perforation, all these things will be there. Treatment is difficult because main problem is the ischemia. So excision you can do of about 4 to 7 mm so that you are removing that area, right? So what we are doing is, when we are excising this conjunctiva, you are removing the enzymes which have been released as the autoimmune etiology, like collagenase enzyme, proteoglycanase enzyme, other inflammatory mediators, Yes, of course, if the perforation is occurring, then you have to do the debridement. You can use the adhesives. We can give the contact lenses. And the last but not the least thing is the lamellar keratoplasty. So one of the indication of your corneal transplantation, partial thickness corneal transplantation or the lamellar keratoplasty is this, right? Another important topic is your interstitial keratitis, and basically you are getting questions related to DD on this interstitial keratitis. We have got the inflammation which is affecting the stroma. Interstitial means when we have affected with the deeper layers of the cornea. Interstitial means there is a problem with the deeper layers of the cornea without primary involvement. Without the primary involvement of the epithelium or the endothelium. Without the primary involvement of epithelium or endothelium, if we have deeper layers involved, and this is interstitial keratitis, and you have to learn definitely the causes. They're always asked. We have measles, typhoid, syphilis, tuberculosis, and idiopathic. These are the main causes. Important syndrome is a Cogan syndrome where you are getting the interstitial keratitis along with the deafness. So this deafness is your sensorineural hearing loss. So this can be associated with vertigo, tinnitus and the deafness. Then we can have the syphilitic interstitial keratitis. Always remember that whenever we are having the congenital syphilis, we have got the early form as well as late form. Early form is having slightly different clinical features in comparison to the late form. So when I'm talking about the interstitial keratitis due to the syphilis, most commonly it is affecting the children between 5 to 15 years of age, while the delayed one is occurring in the patients who are more than 30 years of age. After slight irritative symptoms and ciliary congestion, we have hazy patches. Salmon patches are there, and if they start near the margin, they are going towards the center, and finally whole cornea will become lustreless. So whole cornea is hazy. A very, very typical appearance is a ground glass appearance. So ground glass appearance is again associated with syphilis. Denser spots are there. Iris is dimly visible, and in the severest of form, you can get even whole of the cornea which is opaque. So always remember the ground glass appearance, right? Okay, syphilis is again important in the other aspects also. So you may get the questions related to the syphilis in the other subjects also. So it's an important thing for your integrated questions. So this is your image of the Cogan syndrome. You can get this with respect to hearing loss or tinnitus, vertigo and other things. Meanwhile, devascularization may you can get the brush-like vessels, and we can get the salmon patches. It is important for ground glass appearance. It is important for your salmon patches also, and this opacity is extending a little beyond the vessels. There is often a moderate degree of superficial vascularization. Then after the disease has reached its peak, cornea clears. So now it is beginning to clear slowly from the margin towards the center. As the cloudiness disappears, the vessels becomes obliterated. So permanently afterwards they are remaining. They remain permanently as a fine lines that are actually called as the ghost vessels. So basically ghost vessels are nothing but the remaining superficial vessels which were actually showing the vascularization, right? Previous occurrence of the disease they are showing. Since the infiltration of the cornea is almost entirely limited to the deeper layers immediately anterior to the Reisman's membrane, corneal surface rarely becomes ulcerated. Right? So it is one area, it is one condition where you are having involvement of the deeper layers of the cornea. In the worst cases, cornea may be thickened, but usually improves with some useful vision, but mostly take into consideration that you are going to have the opaque cornea. In interstitial keratitis, another thing which is involved is the uveal tract. So you are also going to get the iritis. Sometimes there is cyclitis also. We can have the keratic precipitate. So in cases of interstitial keratitis, you can also have iridocyclitis. Iridocyclitis means anterior uveitis, and anterior uveitis means keratic precipitate. So you can get that. And even you can get the posterior uveitis, choroiditis can also be there. It is important to understand the pathogenesis. A treatment must be directed to avoid the deleterious results of the iridocyclitis rather than those of keratitis. Now, this is again important. Our treatment is basically based to avoid the deleterious effects of iridocyclitis, uveitis rather than the keratitis. So, the deleterious effects are more of uveitis than of keratitis itself. Syphilitic interstitial keratitis is usually bilateral, and though there is a difference between the involvement of the other eye, and that interval is 3 to 4 weeks. The acute stage lasts for at least 6 weeks, and little improvement can be expected after 18 months. So it is a drastic changes which are occurring. Diagnosis will depend upon your serology. We can do the serology of the syphilis, right? Treatment may, if it is doubtful, if the anti-syphilitic remedies have any influence over the course of keratitis. Why? Because cornea is avascular. So anti-syphilitic remedies are not very, very useful, and partly because reaction is allergic reaction. So it is possible that you can treat this condition with the penicillin. Local treatment may, you can give the lubricants, topical steroids, cycloplegics. Basically, the treatment consists of the treatment of uveitis, anterior uveitis, and afterwards you can do the penetrating keratoplasty, right? Another important keratitis is your disciform keratitis. Disciform keratitis is usually occurring in the adults, and it is unilateral, and there are so many causes. And one thing which is most frequently associated with the disciform keratitis is your viral infection. So first thing that reminds us of the disciform keratitis is the viral infection. The viral infection usually starts from SPK, that we have already discussed in the last session. It is first starting with the superficial punctate keratitis. Now this can come either due to the direct infection, right? Direct infection of the stroma. It is coming from the epithelium, then it's going to the Bowman's membrane, and then it's going to the stroma, or it can be a tissue response also. So tissue response is more common, but it can be a direct infiltration also. The pathology may thus be analogous to the syphilitic interstitial keratitis. So it's very, very similar to that. If I talk about the clinical features, see, in the clinical features of the disciform keratitis, because mainly stroma is involved, it is having again great disc-like areas in the stroma. So you are having these small coin-shaped areas or the disc-shaped areas. They are present in the stroma, and stroma means they are going to lead to the haziness. So this will show the thickening of the cornea. We can have the folds of Descemet's membrane, and a very important thing, the immune ring of Wesley. I think this has been asked so many times, the immune ring of Wesley. This is an important question. It is accompanied by moderate irritation, leaving a permanent opacity. Then it is completely a difficult condition to treat, but generally the symptoms may be ameliorated by the steroids. So whenever there is stromal keratitis, what you have to do is you have to give the steroids along with the antivirals. If you remember this, we discussed that in cases of the keratitis, when it was just the epithelial keratitis, steroids were contraindicated. But in cases of stromal keratitis, you have to give both the steroids along with the antivirals. And when it was metaherpetic keratitis, neither the steroids nor the acyclovir was useful. So I think we have discussed all the non-infective kind of keratitis also, along with the protozoal and helminthic keratitis. We have finished up with the all the corneal ulcers, which is in fact an important topic for your NEET PG 2022. I hope you people are enjoying reading the Parsons along with me. Stay tuned for the next session. Thank you and happy ophthalmology.